So our next topic is the vessels. We're going to talk mainly about the vessels of the brain, but also of the neck in the second half. Pipes going everywhere. That's what it sometimes feels like. Talk about the circle of Willis and how it's distributed. Talk about some of the variants that are worth knowing about because they do have some clinical implications. The dural venous sinuses and then some of the neck vessels. So the circle of Willis, or the cow, should be pretty familiar to most of us. You can divide it into anterior and posterior circulation. The two ICAs supply the anterior circulation, and the two vertebral arteries fuse to form the basilar artery at the back, okay, and form the posterior circulation. You have the posterior communicating arteries bilaterally here that join the anterior and the posterior circulations. And only in about a quarter to a third of us do we have kind of normal anatomy that has a nice ring like this. So most of this room would have some kind of a variant. I know I do. So let's have a look at them. Here's an MR angiogram. Starting at the very bottom, let's start at the posterior circulation first. Here's our cervical cord becoming our medulla. Here's the start of the cerebellum, the tonsils. We got our vertebral arteries running in the pre-medullary cistern, coming up, and they will join right there to form the basilar. Now it's at about the junction of the pons and the medulla, and it may run in the midline, it may run off to the side. If it runs off to the side, it often means that there's a dominant vertebral artery that's kind of pushing it that side. Here it is running in the midline, it continues up, and then it bifurcates right here, the posterior cerebral arteries, okay, which hook around in the ambient cisterns around the cerebral peduncles to supply the occipital lobes. We go back down, there are a couple of branches in those vertebral arteries that are worth knowing. Okay, there's often this little tortuous one that's got a big tonsillar loop, which is a way to find it. This is the pica, the posterior inferior cerebellar artery. So it comes off the vertebral artery as it's sitting off to the side or anterior to the medulla. Okay, and where the vertebral arteries kind of join, or just in the first part of the basilar, you'll get another little bilateral branch coming off. That's the anterior. See it there, the anterior cerebellar artery, AICA. So pica off quite low. It's got a big tonsillar loop. It loops around. And then as the vertebrals become the basilar, you get another branch, the AICA. We continue up. There's a whole bunch of little tiny pontine and labyrinthine arteries, but we don't see them. They're too small to be defined on MRA. And then we come up to almost the top. There's the bifurcation right there into both PCAs, but just before the bifurcation, we have bilateral branches as well, and these are the superior cerebellar arteries. Okay, and there's a little gap between the PCA and the SCA, this little gap here, and it's amazing how small that gap is, and yet we can fit the oculomotor and trochlear nerves through there. Hence, you get eye palsies when you have little aneurysms of the PCA or the SCA right there. So that's the posterior circulation. Let's go back down and follow the anterior circulation up. Here's our ICA. ICA comes up through the carotid canal and it works its way medially and anteriorly. It's got lots of bends in it. This is the petrous portion. We'll talk about this shortly. Our cavernous, all the portions all the way up until we bifurcate. So here's our ICA and here's our bifurcation. Our bifurcation, we'll do the other side, it's a bit easier. Bifurcation, there's one that goes laterally into the Sylvian fissure. Okay, this is the MCA, the middle cerebral artery, and it will often bifurcate or trifurcate out here. And the vessel that goes medially is the ACA, the anterior cerebral artery. And it will be then joined usually by this other ACA with a little ACOM, anterior communicating artery. This patient actually has two little fenestrated ACOM, one of the variants. We can divide these, the main vessels into segments. It's worth knowing that how we call the segments. So when we go to our MCA, this first part is M1 until we get to the bifurcation. M2 runs in the Sylvian fissure, M3 opercular branches that run out, and then M4 are all these cortical branches. And if you want to get funky, you can try and learn all of them, but they're very variable. One of the least variable ones is this, the anterior temporal artery. So that's the M segments. The ACA, we've got an A1, which is the first part, the pre-communicating segment of ACA. Once you're past the ACOM, it's then called A2, and here's our two A2s here. Maybe a little aneurysm there. And our A2s hook back over the GNU of the corpus callosum, and they'll divide into several branches: orbitopolo, frontopolo, pericallosal, and callosomarginal. Don't really need to know them unless you're doing angiograms. So they're our A3 branches. So A1, pre-communicating, A2, post-communicating segment, and A3, the cortical branches. There's our PCOM again, and now our PCA also has segments. The first segment being the pre-communicating segment between the bifurcation of the basilar artery, and there's the PCOM. The P2, which is there's an A and a B, and they stretch around here, around the ambient cisterns into the quadrigeminal plate cistern, and then P3, which are all the cortical branches that go to the occipital lobe. So we've learned a bit about the branches of the circle of Willis. What's it actually mean? Well, it's good to know what supplies all this. Now, all of these, what are there, 6? They're all different vessels. So infarcts, lesions, vascular lesions can affect all of those regions, but affecting different vessels. Now, the classic kind of illustrations we see in textbooks are things like this, where the MCA supplies most of the external surface of the brain. The lateral aspect we're looking at here, the ACA supplies the medial aspect of the frontal lobe. It sometimes gets the parietal lobe as well. The PCA supplies the inferior aspect and lateral aspect of the temporal lobe, obviously the occipital lobe and part of the parietal as well. If we flip it around and look at the medial aspect, you can see that MCA doesn't do much medial at all. Sometimes it pokes its head around and supplies a little bit of the temporal pole, but mainly it's PCA. PCA, obviously the occipital lobe, the posterior aspect of the corpus callosum, but ACA supplies a lot of this medial aspect. Remember how I said that the leg of the homunculus dangles into the interhemispheric fissure? Okay, so the leg will be dangling down here, so you can have an ACA infarct where you only get leg symptoms. Frank did this wonderful diagram that I use almost daily. Okay, now there is variation in this, everyone's different, but in general the posterior inferior cerebellar artery does the inferior and most medial parts of the cerebellum, including the cerebellar tonsils, does a tiny bit of the medulla. Then as we get up, you'll sometimes see aorta supplying the rest of the inferior cerebellum. The aorta usually does the middle cerebellar peduncle, and then the SCA superiors supplying the superior half of the cerebellum. The cerebellum usually has consistent superior blood supply from SCA, but the inferior half of the cerebellum, you've got aorta and pica, and they have a reciprocal relationship. If you have a big pica, with it supplying a lot of the territory, you're going to have a small aorta and vice versa. It's called aorta-pica dominance. And above the tentorium, you can see the classic medial aspects of the frontal lobes being the ACAs. See it there, getting the GNU of the corpus callosum. The PCA supplying the posterior aspects of the brain, occipital lobes, and the splenium of the corpus callosum. And then the big wedge of tissue supplied by MCA. So MCA is a very dominant vessel, and that's why we see, 9 out of 10 strokes will be MCA involved. I won't go into too much detail here in the basal ganglia, but these are very important vessels that you can read about. But we do have little tiny perforating vessels like the lenticular striates, the medials coming off A1, the laterals usually come off M1, the recurrent artery of Hübner, which comes off A1 or A2, and it supplies the caudate head here. These are small little vessels that are end arteries, so there's no collateral supply there. If you infarct there, the tissue's gone. And when you have a large vessel occlusion, like a big M1 or a ICA bifurcation occlusion, they're often the first to infarct because all the cortical branches of MCA get collateralization, so you don't lose the cortex just yet, you tend to lose the basal ganglia. Some examples of these infarcts. Here's ACA, nicely conforming to our medial frontal lobe territory. Here's a big MCA. And note here, it's taking out caudate. This patient's got some variant anatomy, obviously, with recurrent artery of Hübner not really coming off A1. It must be coming off M1, supplying the caudate head. PCA. Okay. It's easy when it's just presented like this, isn't it? So here's our PCA. Note how the PCA supplies that medial aspect of the temporal lobe right down into the temporal pole. Okay, whereas this is all normally MCA. A little bit of MCA. Cerebellar infarcts, this is nice. Not very often in the brain or anywhere in the body do you get a nice straight line. The brainstem you might, and the cerebellum. So this is SCA infarct, and you can see how this infarct affecting the left side, clearly different, and nice straight demarcation between the normal side and that side. That SCA infarct, you can actually see the SCA stopping, there's PCA, there's SCA underneath, and boom, there's the end of the vessel. Here's the other SCA, and you can see it continuing down here. So you can actually see the thrombus stuck and occluding that SCA vessel, which is why we do CT angiograms in acute strokes to define which vessel is occluded and whether a clever neurointerventionalist can put a catheter up through the groin and pull out that clot. An anterior-inferior cerebellar artery, here's our T2, and then we've got our DWI showing you active restricted diffusion there, quite a lot supply, and that's the lateral aspect of the inferior. In this patient, there's a lot of inferior cerebellum supplied by aorta, so they must have a small pica, and you can see that defect going into the middle cerebellar peduncle. Like I said, aorta supplies that. And then pica. The very lower aspect of the cerebellum, this is a lot of the cerebellum taken out by pica. So this is a very dominant pica on the left side here. See how it's kind of got a bit of mass effect and it's pushing across the midline? Pica infarcts can do this. They can look like masses. There's not a lot of space down there. Like Andrew said, the posterior fossa is pretty tight, and little infarcts can cause a lot of swelling and a lot of mass effect. And you just think about what implications that has on the ventricles. Boom. Hydrocephalus, because of that fourth ventricle being completely pushed across. Some variants, lots of variants. Only about 25% have kind of a normal complete. So 3/4 of this room are weird. I know I am. So some of the common variants, we scroll through them. There's our normal one. So our A1 pre-communicating segment might be absent, might be small. Okay, if it is, you'd expect a big ACOM to be able to supply that side, the A2 on that side. PCOM might be hyperplastic or even absent. Our ACOM showed you a case of that already, a fenestrated ACOM or even absent ACOM. Then this one, the fetal PCOM, this is called a fetal posterior communicating artery circulation because in the fetus, our P2s are supplied by the anterior circulation. And then as the vertebro-basilar system matures, it takes over the PCA supply. But sometimes you're left with anterior circulation supplying PCA. And what you've got is a large PCOM, and you have to have either a small or even absent P1 on that side. Sometimes you see a big PCOM, but you also have a normal size P1. That's not really fetal. This, in my experience, tends to be the one I see the most of. And I know I have one. There you go. And I'm fine. All right, let's have a look at some of these. Here's our vertebral basilar coming up, bifurcating into where are we? Sorry. There's our P2s, sorry. And you can see there's not much of a P1 there. So this is a nice dominant. It's actually bilateral. This side's better, isn't it? A large PCOM coming down and supplying P2. And then you have a look and there's our little tiny P1. So it's a hyperplastic P1 on the left side with a dominant PCOM supplying P2. So that's a fetal PCOM. Looks like something's missing here. This A1, here's the normal left A1, but that right A1 is missing. So this is an absent A1. Here's our A2s, both being perfused by that left side. But actually, if you zoom in, you might, with the eye face, see a little vessel. See that little tiny thing coming across? So there is a tiny hypoplastic right A1. They're pretty common. This is a nice variant where you've got A1s that both join. You don't have an anterior communicating segment because they join together and you've got one big A2, which is called an azygous ACA, and then it then divides into a couple of A3 branches there. So you've got bilateral vessels. But you've got this single midline trunk, which is the azygous ACA. A fenestrated ACOM, I've shown you that. And then at the back, you've got this little variant. Now, it's pretty rare, but it's worth mentioning about the P1. Off the top surface of the P1s, you often have little perforating vessels. These are the thalamostriates. And they go into the back of the striatum and also the thalamus, obviously. Little end arteries, a bit like those lenticular striates and the recurrent arteria humna from the anterior circulation. But occasionally you might have one that's absent, and therefore one side supplies bilateral vessels that go into the thalami, and sometimes you might even have an arcade. But if you have this arteria percheron and you're unlucky enough to infarct it, you get this classic kind of edema in the medial aspects of the thalami, because that one little vessel, which comes off one side, supplies a bilateral structure. So this is an arteria percheron infarct, which is a pathognomonic kind of case. There are a couple of variants that from embryology that are a bit weird, and these are the persistent carotid-vertebro-basilar anastomoses, where there's an artery that links the anterior and posterior circulation. The most common in one in about 2,000 is this trigeminal artery, a primitive or persistent trigeminal artery, and then these are far less common. I've got an example here of the trigeminal artery. Have a look at here. Here's our M1, A1 going down. We have our ICA, okay, and it's tortuous here going into the cavernous sinus, and we've got this large branch that traverses the cavernous sinus, actually goes posterior through the back aspect of the sella where the pituitary gland is, and it passes actually through the dorsum, which about half of these do, and then it comes in and to supply the PCA. So this is an anastomosis where ICA is contributing a large trigeminal artery. It's called trigeminal because it goes through cavernous sinus next to the trigeminal nerve, and it supplies the posterior circulation. Note, if we go down, we don't really have a basilar. We've got these little vertebrals that terminate as the picas, and this gives off a few cerebellar arteries, but it's really quite small, and that's because a lot of that blood supply to the PCAs is coming from that trigeminal. Here's a case that we would have shown you. Grab your phones out. Another question for you. Which of these, 6, you can choose multiple, which of these are in the anterior circulation? Which of these are from the anterior, not the posterior? Anterior circulation. A, C, E, F, G, I. How are we going? Nailing it? Yeah, we're getting some. A, C, and F are winning. Okay, A is one of the M2 branches of MCA, so yes. C, this is the ICA, just about to go through the carotid canal here, so yep, that's anterior circulation. E is not, this is the vertebral artery. You can see it coming up here, vertebral artery. That makes G the basilar artery, so G is certainly not. F is a branch of the ACA, so that's anterior circulation. G, no, basilar. And I is the left vertebral artery, so 3 of those, anterior circulation. What are the ones that I didn't tell you? So B, these tortuous ones out here, very superficial, and this is good to know when you're looking at a lateral angiogram. The really tortuous ones are outside the brain, they're in the scalp, and this is a branch of the ECA. This is the superficial temporal artery. D would be the carotid bifurcation, where it just bulges out a bit before it bifurcates, the common carotid bifurcation. F, G, H. H is this kind of tortuous part of the ICA, probably the cavernous segment. And then J would be not an artery, it's a vein. So this is the internal jugular vein on the left. Notice how the right's a little bit bigger. Now, we've seen this slide. I was talking about the meninges. Remember that the dura and the arachnoid go down into the median longitudinal fissure, forming the falx cerebri. At the junction of the falx and the skull in the midline, we have this big sinus here called the superior sagittal sinus. And here it is here running in the midline, and it gets bigger as you go back. That's because it collects more and more blood. It gets a lot of blood from these cortical veins. Okay, you can name them. I don't tend to. The ones I do know about are the Sylvian vein that runs in the Sylvian fissure, And then most of us would have one of these anastomotic veins. They're called anastomotic because they join one vein to another. This is the vein of Trollard, and this is the vein of Labbé. And they're really important because they can infarct or thrombose and cause venous infarct. But notice how Trollard goes up to the superior sagittal sinus, whereas Labbé goes down into the lateral aspect of the transverse sinus. Looking at the base of the skull from on top, these sinuses all kind of collect at the back here, the torcular, and then you've got the transverse sinus, and then the sigmoid sinus because it's S-shaped going down to become the jugular. And then you've got a lot of basal sinuses here. You've got the cavernous sinus, which I'll talk about shortly, which drains the sphenoparietal sinus. Also, the veins from the orbit will join back into there. And then there's a superior and an inferior petrosal sinus, and all roads lead down into this, the jugular foramen, where it will form the internal jugular vein. What's it look like? Here's our falx, and this is a venogram, CT venogram. You can see all these cortical veins draining into the superior sagittal sinus. It should look like a triangle. The posterior triangle is always bigger than the anterior triangle because it gets bigger as you go back. This is the superior sagittal sinus, and then when it hits the transverse sinuses, okay, transverse sinuses left and right, that's the torcular. Okay, notice these little filling defects. These arachnoid villi that both Andrew and I have spoken about. This patient, the right is slightly less sizable than the left, so it's a left dominant transverse sinus. You can see now we're in the sigmoid. The sigmoid sinus has a groove, the sigmoid groove of the temporal bone, and it comes down to exit out through the pars vascularis of the jugular foramen. There's the opposite side one there. Look how that side's much bigger. If we look at it in coronal, you can see the triangle here running in the edge of the falx as it meets the skull, coming down posteriorly to join back here. We also have one that runs in the free edge. It's pretty underdeveloped actually in this patient. You have one here that runs in the free edge. This is the inferior sagittal sinus, the free edge of the falx, and it comes back to join here and become the straight sinus. Okay, and this will drain, this area here is the vena Galen, and it will drain internal cerebral veins, as well as the basal veins of Rosenthal, these here. So this is kind of like a confluence of the internal venous structures, and then you've got the straight sinus back to the confluence here, which is called the torcular. Interestingly, there's a lot of variation with these veins. You can see this MRV, how we come back. This is what the majority of people have. Their superior sagittal sinus comes back, and most, if not all of it, drains into the right transverse sinus, whereas here's our straight sinus here coming back, and it drains predominantly into the left transverse sinus. There is a connection there, but sometimes there might not be. Show you some of the cool reconstructions we can do. There's the superior sagittal sinus, the straight sinus, the gainer valen, the torcular going off to one side. Here's the transverse, and now becoming the sigmoid sinus, and it loops forwards and then down out of the skull to be the internal jugular. And we can do these cool rotation venograms. The cavernous sinus is an awesome spot right next to the pituitary. Here it is here, extending all the way down. Here's our flow voids of our internal carotid artery, the cavernous portion. And with the eye of faith, you can see a couple of little dots here. These are nerves. What nerves are they? Well, Frank dabbled in a bit of graphic design when he started Radiopedia and did this, which, you know, was an okay attempt, but that $500,000 designer course really paid off here. And you can see the pituitary sitting medial to the cavernous sinus, so there's going to be one on the other side. The ICA going straight through the middle of it, and these nerves. From top to bottom, you have the third nerve, oculomotor, the fourth, the trochlear, which is often incorporated into the lateral wall, the sixth, and then VA and VB. They're the trigeminal first division, the ophthalmic division, and the second division, the maxillary division, passing through. The third division, the mandibular division, drops straight down off the trigeminal nerve, the Gaussian ganglion. It drops straight down through the foramen ovale to exit the skull. The other two course forwards to enter the cavernous sinus, which is why you don't see VC in the cavernous sinus. Let's have a look at these arteries coming up the neck. Okay, I've shown you that diagram before, but let's look at the axials. Here is our carotids coming off. So our aortic arch, our standard 3 vessels, which I'll talk about later, brachiocephalic, common carotid on the left and left subclavian. So the left common carotid comes off the aortic arch directly. The right comes off the brachiocephalic trunk, and now they're kind of symmetric. So it's only the first part coming out of the chest where there's asymmetry. Now we have the common carotid. They will ascend in the neck behind the lateral lobes of the thyroid, in the carotid sheath, which has the jugular vein, internal jugular vein lateral to it, and snuggled in here will be the vagal nerve, okay, cranial nerve 10, and they will rise up, and there are no branches of the common carotid. No branches, no branches, no branches until we get up. It will dilate up a little bit and now divides into the internal and external. Okay, see that? About the same level, internal, external, about C5, 6, but that can be variable. So that's the common carotid artery. It occasionally can have some variant origin. It's very symmetric once it gets above out of the chest and doesn't have any branches. Okay, let's talk about the ICA. We keep going up. Carotid, carotid, carotid. Okay, our ICA is here. It doesn't have branches in the neck. Okay, it can be quite tortuous as it is here. And it gets up into the carotid canal to become the intracranial ICA. So there are segments, just like the A1, 2, 3, there are segments, we like to number things. There are 7 segments of the ICA. From the bottom, the cervical segment, and these are really cool because it tells you how many branches you have. You've got no branches. C2 is the petrous part through the petrous temporal bone. It has 2 branches. 3 is a tiny little angular part, the laceral segment. That's because it's over the foramen lacerum. It has no branches. The cavernous segment, we talked about that in the cavernous sinus. It has a couple that go to the through the cavernous sinus and supply trigeminal nerve and pituitary. The clinoid segment, as it curves up underneath the clinoid, anterior clinoid processes. And then you've got the supraclinoid or the ophthalmic segment, and that's where the ophthalmic comes off. Also a branch to the pituitary. And then the last terminal segment or the communicating segment, this has 4 branches. The 2 terminal branches being the ACA goes medially and the MCA goes laterally. And then you've got anterior carotid artery, a really important artery, and the PCOM, which will go back and complete the circular Willis. So you can see here 7 segments, but we've got none, 2, none, 2, none, 2, 4. So a nice way to remember the branches. Here they are here. Now there's no definition exactly where each of these finishes and starts. It's just the vibe, I guess. But when it's in the cavernous segment, I think it's pretty safe to say it's the cavernous segment. Can we see them? So we'll go up to where they go in. Let's have a look at the left side. Here's our petrous portion coming to our lateral portion here. This is where the foramen lacerum will be, which is not really a foramen, it's covered with cartilage. Now it enters into the cavernous sinus, so it's the cavernous segment. See how there's a bit of venous blood in that cavernous segment, and these little filling defects are probably the nerves. Here's our cavernous coming up. This is our clinoid section because it's right above the clinoid, anterior clinoid process. Angling back, supraclinoid or ophthalmic portion. You might see the little ophthalmic artery coming off. You don't, but you can see it there in the orbit anyway. And then finally finishing as the communicating or terminal segment with our M1 and A1 branches, and there's a tiny little PCOM coming off there. So that's our ICA. There can be quite a lot of variation in the ICA. Where it arises from the bifurcation of the common carotid can often be asymmetric. You can do these things. These are called kissing carotids. Look how they come close to the midline and almost touch. So you see them there. So as a ENT surgeon, I would want to know if I'm putting a needle or a scalpel through just there, I would want to know that there's big red sitting at me waiting to bleed. So they're called kissing carotids. Very rarely a carotid might be absent. Here you can see the petrous part and the cavernous part of this right ICA that's there, but clearly not there on the left. You might be able to detect it on the CT. You can see the carotid canal here, and it's nicely orientated there. You're missing it on the other side. So if you don't see a skull-based foramen, it means that there's aberrant anatomy, and the vessel or the nerve going through it must be absent or somewhere else. The ECA has 8 branches, and there's some cool mnemonics. Some anatomists like freaking out poor med students. And we can sometimes see these vessels. The main ones, however, we have the internal mammary. That is an awesome artery. It has like 15 branches. You can write a textbook just on it. But it goes medially towards the pterygoids. And then the terminal branch of the ECA is the superficial temporal arteries here, which go in the scalp. Also, the 2 big arteries down the bottom. We go down the bottom here. Here's our facial artery that grooves the submandibular gland. And in this patient, I think, yeah, there's the lingual artery, which follows the course to the tongue. So they're the 4 big branches. The others are quite small. The vertebral arteries run in the vertebral transverse foramina, okay, which is one of the differentiating features of these vertebrae. And we can see them here, but on the axial it's much better. You can see them coming up. This is the first segment here, V1, because it's pre-foraminal. Now we've got the foraminal coming up in the spine, doing a little loop, and then it comes out of C1 and loops around the lateral aspect. This is the V3 segment, and it has to come out for a good reason. I'll tell you why. Going back into C1, and once it pierces the dura here, okay, it's V4, the intradural component, which will give off the spinal arteries and also pica, and then it will course towards the midline to join in with the contralateral vertebral artery to form the basilar. The vertebral arteries arise from the first part of the subclavian artery. There's V1, pre-foraminal. There's the foraminal segment. Here's our Atlantic segment, comes out of C2, loops around C1. You need this redundant looping because when you turn your head, you don't want that artery to stretch and dissect. So you need that redundancy there, and then the intradural V4 segment. A variant of this is where you might get it coming off a vertebral artery, especially the left comes directly off the aortic arch. That's it right there. Not a variant, but a cool clinical implication of this is if you have a stenosis, occlusion of the first part of the subclavian artery, the vertebral artery, if it's not affected, if its origin is distal to that occlusion, the left arm will be supplied by the vertebral artery, which means you steal blood, subclavian steal. You steal blood from the brain and you get vertebrobasilar insufficiency because the blood is going up the right side, across the brain and leaving the brain, not going into the brain, going back down the left vertebral artery. So it will have retrograde flow down into the subclavian to bypass this stenosis. You've seen this one? All nailed it? All right. So what do we got? We'll go around in clockwise. A is the ophthalmic artery, small, coming off ICA, coursing anterior and lateral to go into the orbit. B is the left A2. C is the left M1. D is the small PCOM on the left. E, now these are all branches of the MCA. These branches here will be M2 branches, so this is an M3 branch, E. F would be PCA, but it's the second segment of PCA because here's PCOM, which means this is P1, P2. G being the 4th segment of the left vertebral artery. H, this is the P2 turning into the P3 segment of PCA. That little one that comes off just before the bifurcation of the basilar artery, remember that little spot there where 3rd and 4th cranial nerves go? This is the SCA, SCA. J, this is an M2 branch. And then K, the petrous portion of ICA. So we've covered variants, especially the cow. We talked a lot about the arterial circulation, arterial vascular supply, and the distribution, and also the dural venous sinuses. Thank you.